Welcome to Medic Talk, everyone. Get ready, because today we're going to be tackling a condition that's a real heavy hitter in the medical world, myocardial infarction, or better known as a heart attack.
That's right. And we're going to arm you with all the knowledge and mnemonics you need to truly understand it, not just memorize facts for an exam.
Exactly. Think of it like this. You're building a house. Rote memorization is like laying bricks without a blueprint. We're going to give you that blueprint so you know why each piece is important in the grand scheme of myocardial infarction.
So let's lay the foundation. You've probably heard that MI is about blood supply getting cut off to the heart muscle, right?
Right, like a traffic jam on a major highway, bringing everything to a standstill.
Yeah, that's the basic idea. But let's go a little deeper. What makes this traffic jam so dangerous is that the heart muscle, unlike other tissues, can't just switch to a backup energy source.
So it's entirely reliant on that constant flow of oxygenated blood.
Exactly. And within seconds of that supply being cut off, the heart muscle cells, they start to panic. They can't contract effectively, and if this goes on for too long, the damage becomes irreversible.
Okay, so time is definitely of the essence here. But before we get into that time is muscle mantra, I'm curious about the types of MI. You mentioned STEMI and NSTEMI.
Right. Imagine two types of roadblocks. One completely shuts down the highway, that's your STEMI, with ST elevation on an ECG. While the other one is more of a partial obstruction, that's your NSTEMI. Both cause problems, but the extent and urgency can differ.
Interesting. So even without that dramatic ST elevation, NSTEMI is still a big deal, right?
Absolutely. Now think about what's happening at the cellular level during those crucial minutes after blood flow is compromised.
All right, let's zoom in on that cellular drama.
Well, those heart muscle cells, or cardiomyocytes, are like tiny powerhouses, constantly contracting to keep blood pumping. But without oxygen, they start losing that ability almost instantly.
So it's like their energy supply gets abruptly cut off.
Precisely. And within 20 to 40 minutes, those cells start to die. This is why prompt treatment is so vital to minimize the extent of this damage.
Okay, so acting quickly is paramount. But here's a question. What about restoring blood flow? Is it always a straightforward solution?
That's where things get really interesting. While restoring blood flow is essential, it can also, paradoxically, cause further damage. We call this reperfusion injury.
Reperfusion injury. So by trying to fix the problem, we could actually make it worse.
In a sense, yes. Imagine rushing water back into a drought-stricken area. It's essential for survival, but it can also cause initial upheaval.
Okay, I'm starting to see the complexity here. What exactly is happening at the cellular level during reperfusion injury?
It's a complex cascade of events. It involves things like oxygen-free radicals and calcium overload. These can trigger inflammation, cell death, and even dangerous heart rhythm abnormalities.
But even though restoring blood flow is critical, we need to be aware of these potential side effects.
Absolutely, and this understanding guides how we manage MI. It's not just about opening up the blocked artery, it's about minimizing damage throughout the process.
That makes sense. Now, what about those terms stunned and hibernating myocardium? I remember those from med school, but I need a refresher.
Think of stunned myocardium as a boxer getting knocked down, but able to get back up after a short while. It's temporary dysfunction that recovers once blood flow is restored.
So it's like a temporary power outage, but the system can reboot itself.
Exactly. Hibernating myocardium, on the other hand, is more like putting a device into low power mode to conserve battery life.
Interesting. So in hibernation, the heart muscle function is reduced, but potentially reversible.
Precisely. And this raises an important question for clinicians. How can we distinguish between stunned and hibernating myocardium to guide treatment decisions?
Because we don't want to overtreat stunned myocardium, but we also don't want to miss an opportunity to revascularize hibernating myocardium, right?
Exactly. Now, before we move on to diagnosis, let's address the root cause of these blockages. Atherosclerotic plaque. You've read about how it builds up in the arteries, right?
Yes, but I was getting confused about the different types of plaque and which ones are the most dangerous.
It's not just about how much plaque is there, but its stability. Think of a vulnerable plaque as a ticking time bomb. It has a thin cap that's prone to rupturing, triggering a blood clot that blocks the artery.
So it's like a fragile dam that can burst suddenly, causing a flood downstream.
Precisely. And this rupture is what often leads to the dramatic presentation of a heart attack. But keep in mind, there's also plaque erosion, which is less dramatic, but can still cause significant blockages.
Okay, so multiple ways that plaque can wreak havoc. But let's talk about recognizing those warning signs in the first place. Diagnosing MI seems like it could be tricky, especially if the symptoms aren't always clear-cut,
You're absolutely right. The classic chest pain, shortness of breath, radiating arm pain, those can be textbook. But MI can be a master of disguise.
meaning it can mimic other conditions.
Exactly. Think about gastrointestinal issues, musculoskeletal problems, even anxiety attacks. They can all present with similar symptoms, making diagnosis is a real challenge.
Wow, so we can't just rely on those classic symptoms. What else do clinicians look for?
Thorough patient history, a detailed physical exam, and of course the ECG. But even the ECG isn't foolproof.
Right, because we have those different types of MI.
Hmm.
STEMI might show those classic ST elevations, but NSTEMI can be more subtle.
Exactly. We might need to look for other clues, like the presence of cardiac enzymes in the blood to confirm a diagnosis.
So it's like putting together a puzzle, considering all the pieces of information before arriving at a conclusion.
Precisely. And misdiagnosis does happen, particularly in younger patients or those with atypical presentations. That's why having a high index of suspicion is so crucial.
It's a reminder that we should never dismiss any symptom, especially when it comes to potential cardiac issues.
Absolutely. Now, once we have a diagnosis, the focus shifts to treatment, and as we've discussed, time is of the essence.
So what are the primary goals of treatment?
First and foremost, we need to restore blood flow as quickly as possible to salvage that precious heart muscle. This is where reperfusion therapy comes in.
Okay, so this is where we try to unblock the highway using medications or procedures.
Exactly. We can use clot-busting drugs called thrombolytics, or we can go for a more mechanical approach with angioplasty or bypass surgery.
Okay, before we unpack those specific reperfusion therapies, I want to circle back to something you mentioned earlier. Reperfusion injury. How do we balance the need to restore blood flow with the risk of causing further damage?
That's a great question, and it's something that cardiologists are acutely aware of. The benefits of reperfusion far outweigh the risks in the case of a heart attack, but minimizing reperfusion injury is a constant consideration.
So it's about finding that sweet spot, restoring blood flow as effectively as possible while mitigating those potential side effects.
Exactly. And now let's take a closer look at those reperfusion strategies, starting with thrombolytic therapy.
Okay, thrombolytics is the clot-busting drugs, right?
Yeah.
How do they actually work?
Think of them as specialized cleaning crews sent in to break up that traffic jam in the artery. They activate the body's natural clot-dissolving system, breaking down the fibrin meshwork that holds the clot together.
So they're essentially jump-starting the body's own repair mechanisms.
Precisely. And they're most effective when administered early after symptom onset, ideally within the first few hours.
Right. Time is muscle.
Yeah,
But you mentioned earlier that thrombolytics aren't without their risks.
that's true. The primary concern is bleeding. These medications can increase the risk of hemorrhagic complications, so they're not suitable for everyone.
So it's a balancing act, weighing the benefits against the potential risks.
Exactly. The decision to use thrombolytics is individualized, taking into account the patient's specific situation and risk factors.
Now, what about angioplasty? How does that procedure work in restoring blood flow?
Angioplasty, also known as percutaneous coronary intervention or PCI, is a minimally invasive procedure. We insert a thin catheter, a flexible tube, into a blood vessel, usually in the groin or arm, and guide it to the blocked coronary artery.
So it's like threading a tiny pipe cleaner through the bloodstream to reach that blockage.
That's a great analogy. Once the catheter reaches the blockage, a small balloon at its tip is inflated, compressing the plaque against the artery wall and widening the narrowed passage.
So it's like creating more space for blood to flow through that artery.
Exactly. In many cases, we also implant a stent during angioplasty.
A stent. Remind me what that is.
A stent is a small, expandable mesh tube that acts as a scaffold, supporting the artery and preventing it from collapsing or re-narrowing after the procedure.
So it's like putting in a support beam to reinforce the artery and ensure long-term patency.
Precisely. Angioplasty is often the preferred reperfusion strategy, especially when it can be performed quickly by experienced interventional cardiologists.
Now, you mentioned bypass surgery is another option. When is that typically considered?
Bypass surgery, or coronary artery bypass grafting, CABG, is a more invasive procedure, usually reserved for cases where angioplasty isn't feasible or hasn't been successful.
So it's like taking a detour around a major roadblock.
Exactly. We take a healthy blood vessel from another part of the body and graft it onto the coronary artery, bypassing the blockage.
Creating a new route for blood to flow, like building a bypass around a congested city. That sounds like a pretty major surgery.
It is, but it can be highly effective in restoring blood flow and improving long-term outcomes for patients with complex coronary artery disease.
Okay, so we've covered the major reperfusion strategies, but we also know that medications play a crucial role in MI management, both in the acute setting and for long-term prevention.
Absolutely. Medications are a cornerstone of MI treatment, and we'll dive into those details, including those powerful P2Y12 inhibitors you mentioned earlier, in the next part of our deep dive.
Great. I'm looking forward to unpacking the world of medications and understanding how they fit into the bigger picture of MI management.
And we'll explore some cutting-edge advancements in cardiology that are changing the way we approach MI, from novel medications to minimally invasive procedures.
Sounds fascinating. Can't wait to continue this deep dive. Until next time, keep those brains engaged and those hearts healthy.
We'll see you soon. Before we jump into the medications, it's worth revisiting this idea of misdiagnosis. It's a surprisingly common issue with MI, even in a hospital setting.
That's a sobering thought. We talked about how MI can mimic other conditions, but I'm curious about specific examples. What kinds of cases often lead to misdiagnosis?
Well, think about a patient presenting with epigastric pain. The kind of discomfort you feel in the upper abdomen. It's easy to mistake this for indigestion, especially if the patient mentions recent overeating or heartburn.
Right, because we associate heart attacks with chest pain, not necessarily stomach discomfort.
Exactly. And even if they're sweating or shortness of breath, those symptoms might not be enough to raise a red flag, particularly if the patient feels some relief after taking antacids.
Wow, so even those classic accompanying symptoms can be misleading in some cases.
Absolutely. Then there are cases where MI pain gets attributed to a musculoskeletal cause, chest pain, tightness, even tenderness in the chest wall. These could easily be mistaken for muscle strain or inflammation, especially if the patient has a history of those issues.
I imagine that's even more common in younger patients who might not fit the typical profile of someone having a heart attack.
Precisely. There's often a subconscious bias to think of MI as an older person's problem, which can delay diagnosis in younger individuals. And as we know, that delay can have devastating consequences.
It's a crucial reminder that heart attacks can happen at any age, and age alone shouldn't rule out the possibility.
Absolutely. Now, another challenge is the interpretation of the ECG. While the ECG is an invaluable tool, it's not always straightforward.
Right, because not all ECG changes are indicative of MI. We talked about how other conditions can mimic those patterns.
Exactly. Think about pericarditis, inflammation of the sac surrounding the heart. It can cause changes on the ECG that might look like MI, especially to an untrained eye.
So it requires careful analysis and correlation with the patient's clinical presentation.
Precisely. And even when there are ischemic changes on the ECG suggesting reduced blood flow to the heart, we have to be cautious. These changes could be pre-existing or due to other factors that aren't related to a heart attack.
So it's about considering the whole picture, not just relying on one piece of data.
Exactly. The ECG is a powerful tool, but it's only one piece of the puzzle. We need to integrate it with the patient's history, physical exam findings, and other diagnostic tests to make an accurate diagnosis.
Okay, let's shift gears now and dive into the world of MI treatment. We know that reperfusion therapy is paramount. But what are some of the specific strategies used to manage MI and improve outcomes?
Well, as we've discussed, reperfusion therapy is the cornerstone of acute MI management. Whether it's medical reperfusion with thrombolytics or mechanical reperfusion with angioplasty or bypass surgery, the goal is to restore blood flow as quickly and safely as possible.
Right, and the choice between these approaches depends on a number of factors, such as the patient's presentation, time since symptom onset, and available resources.
Exactly. It's a personalized approach tailored to each patient's unique circumstances. Now let's unpack those treatment strategies in more detail, starting with thrombolytic therapy.
Okay, so thrombolytics are those clot-busting drugs. What's the mechanism behind their action?
They work by activating the body's own clot-dissolving system. Imagine sending in a specialized cleaning crew to break up that traffic jam in the artery.
So they're not directly breaking down the clot, they're enhancing the body's natural ability to do so.
Precisely. They target a protein called plasminogen, converting it into plasmin, which is the body's primary clot-busting enzyme.
Fascinating. So it's a targeted approach, leveraging the body's own mechanisms.
Exactly. Now, thrombolytic therapy is most effective when given early after symptom onset, ideally within the first few hours before that damage becomes irreversible.
Right, time is muscle. But we've also discussed the potential risks, particularly bleeding complications.
Yes, and that's why the decision to use thrombolytics is made on a case-by-case basis, carefully weighing the benefits against the risks for each individual patient.
Okay, that makes sense. Now, what about angioplasty? How does that procedure work in restoring blood flow?
Angioplasty, or percutaneous coronary intervention, PCI, is a minimally invasive procedure that involves threading a thin catheter through a blood vessel, usually in the groin or arm, and guiding it to the blocked coronary artery.
So it's like a delicate plumbing job navigating through the body's intricate network of vessels.
Exactly. Once the catheter reaches the blockage, a small balloon at its tip is inflated, compressing the plaque against the artery wall and widening the narrowed passage.
So it's like inflating a tiny balloon to create more space for blood to flow. And you mentioned stents being used in conjunction with angioplasty.
Yes, stents are often implanted during angioplasty to help keep the artery open and prevent it from re-narrowing after the procedure.
They act as a scaffold supporting the artery from within.
Precisely. Now, angioplasty is a very effective reperfusion strategy, particularly when performed promptly by experienced interventional cardiologists.
Now, you mentioned bypass surgery as another option. When would that be considered over angioplasty?
Bypass surgery or coronary artery bypass grafting, CABG, is a more invasive procedure, so it's generally reserved for cases where angioplasty isn't feasible or hasn't been successful.
So it's like taking a detour around a major roadblock when the main route is impassable.
That's a great analogy. During bypass surgery, we take a healthy blood vessel from another part of the body, often the leg or chest wall, and graft it onto the coronary artery, bypassing the blocked segment.
Creating a new route for blood to flow, like building a bypass around a congested city. It's a major surgery, but it can be life-saving in certain situations.
Absolutely. Now, in addition to reperfusion therapy, medications play a crucial role in both the acute management of MI and long-term prevention.
Right, we can't just unblock the highway and call it a day. We need to address those underlying factors that contribute to heart attacks in the first place.
Exactly. And one of the key strategies is dual antiplatelet therapy, or DAPT.
DAPT. That sounds familiar. We briefly touched on it earlier. Can you remind me what that entails?
DAPT involves using two antiplatelet medications simultaneously to prevent blood clot formation. Think of it as a double-layered security system to keep those arteries clear.
Makes sense. What are the specific medications used in DAPT?
The first antiplatelet agent is usually aspirin, a medication that's been used for decades to prevent heart attacks and strokes.
Aspirin, that over-the-counter pain reliever.
The very same. It works by inhibiting the production of thromboxane A2, a substance that promotes platelet aggregation, the clumping together of platelets that leads to clot formation.
So it's interfering with that initial step in the clotting cascade.
Precisely. Now, the second antiplatelet agent in DAPT is typically a P2Y12 inhibitor.
Okay, those are the ones you mentioned earlier. Can you refresh my memory on how they work?
P2Y12 inhibitors are a class of medications that block a specific receptor on the surface of platelets, preventing them from sticking together and forming clots.
So it's like putting a sticky note over that receptor, preventing platelets from getting the signal to aggregate.
That's a great way to visualize it. Some common P2Y12 inhibitors include clopidogrel, prasugrel, and ticagrelor.
Okay, so DAPT combines aspirin's general anti-clotting effect with the more targeted action of a P2Y12 inhibitor.
Exactly. And this combination therapy has been shown to significantly reduce the risk of recurrent heart attacks, strokes, and other cardiovascular events.
Sounds like a powerful weapon in our arsenal against MI.
It is. Now, the duration of DAPT depends on the individual patient and the specific clinical scenario. For example, patients who've undergone angioplasty with stent placement typically stay on DAPT for at least 12 months.
Why is that? Is it related to the stent itself?
Yes, stents, while effective in keeping arteries open, can also trigger an inflammatory response and increase the risk of clot formation in the early stages after implantation.
So DAPT provides that extra layer of protection while the stent is integrating into the artery wall.
Precisely. Now, in addition to antiplatelet agents, other medications play crucial roles in managing NI. We've already touched upon beta blockers, which help slow down the heart rate and reduce blood pressure, lessening the workload on the heart.
Right, it's like giving the heart a much-needed break after a stressful event.
Exactly. And beta blockers have been shown to improve survival rates and reduce the risk of complications after MI.
Now, what about ACE inhibitors? You mentioned those earlier as well. How do they contribute to MI management?
ACE inhibitors, or angiotensin-converting enzyme inhibitors, are another important class of medications. They interfere with the renin-angiotensin-aldosterone system, a complex hormonal pathway that regulates blood pressure and fluid balance.
So they're like traffic controllers, helping to regulate the flow of blood and fluids throughout the body.
That's a great analogy. ACE inhibitors have multiple benefits after MI. They help lower blood pressure, reduce the strain on the heart, and protect the kidneys from damage.
It sounds like they're real multitaskers, working on several fronts to support the body's recovery.
Exactly. And studies have shown that ACE inhibitors can improve survival rates and reduce the risk of heart failure and other complications after MI.
Okay, so we've talked about medications that manage the immediate aftermath of MI. But what about long-term prevention? What strategies are employed to prevent future heart attacks?
Excellent question. Long-term prevention of MI involves addressing those underlying risk factors that contribute to atherosclerosis, that buildup of plaque in the arteries.
Right, we discussed how atherosclerosis is the root cause of most heart attacks.
Exactly. And one of the key players in atherosclerosis is cholesterol, specifically LDL cholesterol, the bad cholesterol.
The one that's often compared to sludge clogging up the arteries.
Precisely. And that's where statins come in.
Ah, statins, those cholesterol-lowering medications. They've been in the news a lot lately.
They have. Statins are a class of medications that help lower LDL cholesterol levels, slowing down the progression of atherosclerosis and reducing the risk of heart attacks and strokes.
So they're like the cleanup crew, helping to remove those cholesterol deposits and keep the arteries clear.
That's a great way to put it. And statins have become a cornerstone of preventive cardiology, significantly reducing the incidence of heart attacks and strokes worldwide.
They've definitely revolutionized the way we approach cardiovascular disease.
Absolutely. Now, in addition to statins, lifestyle modifications are equally important in preventing MI.
Right, we can't just rely on medications to do all the work. We need to be proactive in our own heart health.
Exactly. Lifestyle modifications include things like maintaining a healthy weight, engaging in regular physical activity, eating a heart-healthy diet, and avoiding smoking.
So it's about making those healthy choices that benefit both our hearts and our overall well-being.
Precisely. And these lifestyle changes, combined with appropriate medical management, can significantly reduce the risk of MI and improve long-term outcomes.
It's a team effort, working together with our healthcare providers to take charge of our heart health.
Absolutely. Now, as we delve deeper into the intricacies of MI management, it's important to recognize that treatment approaches have evolved significantly over the years.
That's true. Medical advancements have led to more effective therapies and improved survival rates for heart attack patients.
Absolutely. And one of the most significant advancements in recent years has been the development of newer, more potent medications.
Can you give us some examples of these newer medications? What's on the horizon for MI treatment?
Certainly. One example is the emergence of PCSK9 inhibitors.
PCSK9 inhibitors. Those ring a bell, but I need a refresher.
PCSK9 inhibitors are a relatively new class of cholesterol-lowering medications that work differently from statins.
So they're like statins 2.0.
In a way, yes. They target a specific protein called proprotein convertase syptylysine type 9, or PCSK9, which plays a role in regulating LDL cholesterol levels.
So like specialized assassins targeting that specific protein to lower LDL cholesterol.
That's a great analogy. And studies have shown that PCSK9 inhibitors can dramatically lower LDL cholesterol levels, even in patients who haven't responded well to statins.
Wow, so they're like a powerful weapon in the fight against high cholesterol.
Exactly. And PCSK9 inhibitors have shown promise in reducing the risk of MI and other cardiovascular events, especially in high-risk patients.
It sounds like they're a real game changer in the field of cardiology.
They certainly have the potential to be. Though another exciting development in MI management is the increasing use of minimally invasive procedures.
Minimally invasive procedures. Can you elaborate on those?
Certainly. Minimally invasive procedures are techniques that allow us to access and treat the heart without making large incisions.
So it's about reducing the trauma of surgery and promoting faster recovery.
Exactly. One example of a minimally invasive procedure used in MI management is transcatheter aortic valve replacement, or TAVR.
TVR, remind me what that is.
TVR is a procedure used to replace a narrowed aortic valve, a condition that can sometimes contribute to heart failure and other complications after MI.
So it's like replacing a faulty valve in the heart's plumbing system.
That's a great way to visualize it. Traditionally, aortic valve replacement involved open heart surgery, a major procedure with a significant recovery period.
Right. Open heart surgery is a big deal.
It is. But with TAVR, we can insert the new valve through a catheter, typically in the groin or chest, and guide it to the heart.
So it's like threading a tiny umbrella through the bloodstream to reach the heart and replace the faulty valve.
That's a great analogy. TAVR is a remarkable advancement, allowing patients who might not have been candidates for open-heart surgery to receive life-saving treatment.
It's amazing how far medical technology has come.
It really is, and these advancements are continually improving outcomes for patients with MI and other cardiovascular conditions.
Now, as we wrap up this discussion of MI treatment, it's important to acknowledge that managing MI is a team effort.
Absolutely. It involves a multidisciplinary approach with cardiologists, nurses, pharmacists, and other healthcare professionals working together to provide comprehensive care.
So it's like an orchestra, with each member playing a crucial role in the symphony of MI management.
That's a beautiful way to put it. And this collaborative approach is essential in optimizing patient outcomes and improving quality of life.
It's a testament to the power of teamwork in healthcare.
Exactly. Now, as we reflect on everything we've learned about myocardial infarction, it's clear that this condition is complex and multifaceted.
It is. From understanding the underlying mechanisms to recognizing the diverse presentations and implementing effective treatment strategies, managing MI requires a deep understanding of cardiovascular physiology and a commitment to patient-centered care.
Precisely. And as we continue to learn more about MI, we're constantly refining our approaches and developing newer, more effective therapies.
It's an ever-evolving field driven by a relentless pursuit of knowledge and a desire to improve patient outcomes.
Absolutely. And with each advancement, we move closer to a future where MI is less of a threat and more of a manageable condition.
That's an encouraging thought. Now, before we conclude our deep dive into MI, I'd like to revisit that thought-provoking question you posed earlier. How can understanding the cellular mechanisms of MI, like reperfusion injury, guide the development of future therapies?
It's a question that continues to drive research and innovation in the field of cardiology. By unraveling the intricate cellular events that occur during MI, we can identify potential targets for new therapies.
So it's about understanding the enemy to develop better weapons against it.
That's a great way to put it. For instance, ongoing research is exploring ways to mitigate reperfusion injury. That paradoxical damage that occurs when blood flow is restored to the heart muscle.
Right. We talked about how reperfusion, while essential, can also trigger a cascade of harmful events at the cellular level.
Exactly. And by understanding those cellular pathways, researchers are developing strategies to protect the heart from reperfusion injury, potentially reducing the extent of damage and improving outcomes.
So it's about finding ways to make reperfusion safer and more effective.
Precisely. And this is just one example of how understanding the cellular mechanisms of MI can guide the development of future therapies.
It's exciting to think about the potential for new treatments that could revolutionize MI management.
Absolutely. And as we continue to delve deeper into the mysteries of the heart, we can expect even more groundbreaking discoveries in the years to come.
It's a journey of scientific exploration and innovation, all with the goal of improving the lives of patients with MI and other cardiovascular conditions.
Precisely. Now, as we wrap up our deep dive into myocardial infarction, I'd like to leave you with a final thought. Never underestimate the power of knowledge.
That's a powerful statement.
It is. By understanding the intricacies of MI, from its underlying mechanisms to its diverse presentations and treatment strategies, we empower ourselves to make informed decisions, advocate for our own health, and contribute to the advancement of cardiovascular care.
It's a call to action, a reminder that we all have a role to play in the fight against heart disease.
Exactly. And by working together, sharing knowledge, and embracing innovation, we can make a real difference in the lives of those affected by MI and other cardiovascular conditions.
It's a message of hope and a testament to the power of human ingenuity in tackling one of humanity's greatest health challenges.
Absolutely. And as we continue to learn, explore, and innovate, the future of MI management looks brighter than ever.
It's an inspiring thought, and one that gives us all reason to be optimistic about the future of cardiovascular health.
Indeed. Now until next time, keep those hearts healthy and those minds curious.
And stay tuned for more deep dives into the fascinating world of medicine.
You know, as we wrap up our deep dive into MI, there's one aspect we haven't touched on yet, and that's the psychological impact.
That's a great point. We focus so much on the physiological aspects, but a heart attack is a major life event. It's bound to have a significant emotional impact.
Absolutely. You know, It's not just about surviving the event itself, it's about navigating the aftermath, the fear, the anxiety, the uncertainty about the future.
It's like having your world turned upside down. Suddenly, you're forced to confront your own mortality, and that can be a very difficult thing to process.
Precisely. And this psychological impact can manifest in many ways. Some patients experience depression, others struggle with anxiety, and many report feeling a sense of vulnerability they haven't felt before.
So addressing this psychological component is crucial, not just for the patient's overall well-being, but also for their recovery.
Exactly, and that's where cardiac rehabilitation comes in.
Okay, I've heard of cardiac rehab, but to be honest, I'm a bit fuzzy on the details. What exactly does it entail?
Well, cardiac rehabilitation is a comprehensive program. It's designed to help patients recover from a heart attack and improve their overall cardiovascular health. It's like a holistic boot camp for the heart, combining exercise, education, and counseling to address both the physical and emotional aspects of recovery.
So it's not just about getting back in shape physically.
Not at all. Exercise is definitely a key component. Helping to strengthen the heart muscle, improve cardiovascular fitness, and reduce the risk of future events. But the education and counseling aspects are equally important.
What does this involve? What kind of topics are covered?
Well, education focuses on empowering patients with knowledge about their condition, their risk factors, and the lifestyle modifications they can make to improve their heart health.
So it's about giving patients the tools they need to take control of their own recovery and make informed decisions about their health.
Exactly. And counseling provides a safe space for patients to process their emotions, address any anxieties or fears they might have, and develop coping mechanisms to navigate the challenges of living with a heart condition.
It sounds like a truly holistic approach, recognizing that healing goes beyond just addressing the physical symptoms.
Precisely. And studies have shown that cardiac rehabilitation can be incredibly beneficial for MI patients. It improves survival rates, reduces the risk of hospital readmissions, and significantly enhances quality of life.
That's fantastic. It's encouraging to know that there are resources and programs available to support patients throughout their recovery journey.
Absolutely. Now, as we wrap up our deep dive into the world of myocardial infarction, I want to emphasize that this condition, while serious, is not a death sentence.
That's an important message of hope to leave our listeners with.
It is. With prompt diagnosis, appropriate treatment, and a commitment to lifestyle modifications, many patients can go on to lead long and fulfilling lives.
It's a reminder that we have the power to influence our own health outcomes.
Exactly. And while we can't control every aspect of our health, we can certainly make choices that reduce our risk and improve our odds.
Absolutely. Now, before we sign off, I want to thank you for taking us on this incredible deep dive into the world of myocardial infarction. I feel like I've gained a whole new level of understanding, not just about the condition itself, but also about the importance of a holistic approach to patient care.
It's been my pleasure, and to all our listeners out there, I encourage you to stay curious, keep learning, and never underestimate the power of knowledge when it comes to your health.
That's great advice. Knowledge is power, and the more we know, the better equipped we are to make informed decisions about our health and advocate for ourselves and our loved ones.
Exactly. Until next time, keep those hearts healthy, those minds sharp, and never stop exploring the fascinating world of medicine.
And to all our aspiring healthcare professionals, remember that every patient is a unique individual with their own story to tell. Listen carefully, empathize deeply, and never lose sight of the human connection that lies at the heart of medicine.
Well said. Until next time, stay well.
Take care, everyone.